righty, good afternoon, everybody. I'm Bill Golden, Medical Director at Arkansas Medicaid. I'm with Ann Sanifer, who's the chief of the PCMH activities, and she laughs. We're pleased to have you here. We're trying to do quarterly webinars. We have a pretty busy agenda today, and if you've seen, we're going to talk a little bit. Why don't you go to the next slide there? We will not, actually, Ann and I won't be doing a lot of the talking here. We, as promised, will have a little discussion from the UAMS Center about health literacy. We'll talk a little bit about how the care plans are going. And I know that AFMC has been looking at the Medicaid care plans. I've been hearing also tales from the Blue Cross review. So there is still some activity and work to be done there, but I think we've made steady progress. We'll have an update about how our new data system for Medicaid is going to be going online in the near future. And once we get that over and done with, then we can do all sorts of new and better things for the PCMH program. And we'll go over the shared savings situation and where we are with that. And then finally, we'll talk a little bit about the program, CPC Plus, PCMH in general. Open it up for your comments and questions through the text box. I'm told in the background we have close to 250 phone lines open, so great turnout for a quasi-holiday Friday. So thank you for dialing in. So having said that, we are pleased to have Dr. Tina Moore here from the Director of Programs and Services at the UAMS Center for Health Literacy, and she's going to talk to you a little bit about tools and activities for health literacy. So thank you for joining us.
Thank you, Dr. Golden. It's good to be here today. So I'd like to spend the next few minutes providing some insight into health literacy assessment for Transformation Activity J. And the information I share will be based not only on evidence from the research, but also on experience implementing health literacy screening with patients at our institution and at clinics across the state. So you're probably familiar with the Activity J 3 parts. First, it's to administer a validated health literacy assessment. Second, to evaluate those results. And third, to have something in place, an intervention to address those that are identified as having low health literacy. So we will start by making sure we're all clear what is meant by health literacy. This is the formal definition from the Institute of Medicine. It's the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Now, this differs from just literacy. Literacy being able to read, write, and compute without regard to context. Often, when we hear literacy, we just think of reading. Health literacy are all of these skills and communicating in the context of healthcare. So this means being able to navigate our complex healthcare system. It could be filling out forms, locating providers and services, being able to share personal information, like when one's asked to provide their health history, engaging in self-care, managing chronic diseases. Often in healthcare, patients have to work with numbers. This could be using nutrition labels to calculate carbohydrates, monitoring one's blood sugar. Dosing medication often requires not just reading, but being able to use numbers, and the challenge of understanding risk for treatment options. Health literacy really comes into play in following instructions from providers. In fact, often when we see non-compliance or non-adherence that we feel maybe just patient behaviors, it's actually related to low health literacy and misunderstanding of instructions. So DHS did not specify which health literacy tool or screening or measure had to be used. Each clinic gets to pick which one fits best in their practice. And if you do a search, you're going to find several. Some are better for the clinical setting, and some are more appropriate for research. These are 5 that at the Center for Health Literacy we have found validated, reliable research supporting their use. We use the single health literacy screening question. I will elaborate why. That one has been selected for our institution. But first, let's start by why would you even want to assess and address health literacy, aside from it being an activity this year? Well, addressing health literacy may actually help your practice meet other PCMH metrics. As described in the task I mentioned previously, the patients with low health literacy are the ones that you may be struggling to meet some of your other metrics because they're missing their follow-up appointments. They're less likely to have preventative measures like screenings, immunizations, getting their well care visits. They're the ones that might struggle to follow their medication dosing regimens. And they may struggle to manage chronic illnesses like diabetes and hypertension. So by addressing health literacy and providing intervention to those that you identify as having low health literacy, you may actually see improvement in some of your other quality metrics. So this is a single health literacy screening question, and it is literally just one question. How confident are you filling out medical forms by yourself? Extremely, quite a bit, somewhat, a little, or not at all. If patients answer 3, 4, or 5, that indicates inadequate health literacy. Now, the way it's administered at our institution, we have this card printed on a laminated sheet, and it's read aloud to patients. It will depend on your clinic workflow where this works best. It's often asked at intake during vitals. The reason this one is selected, it's the shortest, so therefore most practical for a clinical setting. Some of the other screening are not screening, they're actually measures, the newest vital sign, the S-TOFLA, and the REALM. Patients may feel less threatened with a single health literacy screening question than some of the other measures that seem more like a test of the patient. Some actually require, like the newest vital sign is an excellent health literacy measure, but it does require mathematical calculations and takes a little bit of time. And the single health literacy screening question was actually validated against these other measures, including the newest vital sign with an 82% accuracy. And this specific screening question fared better than the other screening ones across demographics. So it's currently implemented in various large health systems, including UMS, with over 40,000 patients to date. And it's much easier to add a single health literacy screening question to your EMR with a dichotomous result of adequate or inadequate health literacy than some of the other tools require scoring first, and they have multiple levels of results. And if it's in the EMR just as a dichotomous variable, it's much easier to use for maybe population health management. Some clinics use it for risk stratification. Keep in mind, as with all self-reported questions, false negatives are possible, but as I stated before, this has been validated against the newest vital sign with high accuracy, and this is just more practical for a clinical setting where the others may be best served in research. So how often should you screen patients or assess their health literacy levels? Health literacy is considered stable over time. Now certainly, one's health literacy can vary for some obvious reasons. You may have a patient that in their 40s had adequate health literacy, but as they age due to cognitive decline, their health literacy could change. But the research does not point to doing this over and over. Right now, we're doing it every 3 years until the research suggests otherwise. So the golden question is, what do you do when the patient fails the health literacy screening? Once you identify the patient, then what? Everyone can do this. You have the power in your clinic right now to implement health literacy best practices to give point-of-care intervention. So here are some basic health literacy best practices. Limit the written information that's given to a patient. If a patient tells you that they struggle to fill out medical forms by themselves, you obviously do not want to hand them a 10-page packet of medical forms to fill out by themselves. So that's a little bit of common sense. They may need some assistance. Always use plain language in written and verbal communication. Plain language is communication that a patient understands the first time they hear it or the first time they read it. It includes using everyday words that people are used to rather than jargon words. In healthcare, we often get an everyday vernacular that's not common to someone that's not in healthcare. For example, if you're talking to a patient about their hypertension, it'd be better to say high blood pressure. If you're talking to a patient about their glucose levels, it'd be better to say blood sugar. Slow down when you're talking with the patients and just speak clearly and concisely. And using TeachBack, in an ideal world, all patients would receive TeachBack. But at a minimum, we should do this with our patients that are identified as having low health literacy. Because think about this. As a provider, maybe instructions are provided to a patient. When they leave, if they didn't truly understand those instructions, they may go home and you think they're being non-compliant by not following your instructions. The problem is they didn't understand them in the first place. So teach back is having the patient repeat the information or instructions back in their own words to confirm understanding. It's not threatening to the patient. It's not a test to the patient. You put the ownership on yourself to make sure that you explained your information clearly. And also use patient tools in education that are made for patients with low health literacy. This means they'll be written at a 6th grade level or below. And for example, if you're wanting to send home some information, a newly diagnosed diabetic, you don't want to send home a booklet that has multiple pages written at a college level, because that's not going to help that patient in any way, shape, or form if they're not able to read it. And use materials that are designed using plain language best practices. So I want to ask you a question. I want you to think about it for a second. As I was going through this information, you may have thought, well, this is such a small percentage of my patient population. If I even ask the 50 this year, I'm probably only going to pick up a couple that actually would fail the health literacy screening question. So what are your thoughts? What do you think the average number is of your patients? What's the percentage that have low health literacy? Well, statistics show, and the research shows, that in Arkansas, 37% of the population has low health literacy. So that means in your waiting room, for every 10 people, about 4 of them will struggle to understand health information and to navigate our complex healthcare system. We can all struggle from time to time, but 37% are low or basic or below basic health literacy. So if you need some additional support or tools, feel free to reach out to Allison Caballero at the Center for Health Literacy, and we can offer support on EMR integration, developing clinic workflow, or any staff or provider training that you need.
Thank you very much. And again, we kind of designed this activity this year to kind of give practices, PCMH as kind of a sampler or just an experience using a health literacy tool to see if it helps them with their outreach, identifying people who might need attention by the care coordination team. So again, we try to do something where you get some experience without putting a lot of burden on your staff. So are there any questions that have floated in or comments? Well, if you have comments or questions, we can circle back later on in the call. And thank you for that great presentation.
Thank you.
Why don't we shift along here? And Shelley Ruth is back. We don't want. Should we tell everybody where you've been? Or
Sure.
you'll get. Yeah, no, you'll get. You can send snarky comments to Shelley, but she just got back from some time in Hawaii visiting family.
Visiting family that lives there.
And grandkids.
And then the grandbaby.
Yeah.
So anyway, time well spent. So let's talk about care plans. This is obviously the hot topic, has been for several years. So to get started, so the QA team will review and validate care plans based on what is stated in the 2017 PCMH Program Policy Addendum. According to the 2017 Policy Addendum, each care plan must include the following, and you can see we've got those listed up here. Documentation of the beneficiary's appropriate problem list, which is active, significant, and clinical condition. Instruction for follow-up. The documentation should include the timing of any of a future follow-up visits related to the problem. Assessment of progress to date. This would be documentation and assessment of each problem, such as the stability or change of condition. And also, the care plan should be updated at least twice within a 12-month period. So documented update to the plan of care, which would include any active problems. In addition to ensuring that each care plan contains these elements, the PCMH must indicate if at least 80% of the high priority beneficiaries have a care plan in the medical record, and that each attested care plan has all 4 required elements. This will be done by completing the attestation questions in the AHIN portal, which are located under the 12-month activities, and selecting at least 80% of the high priority beneficiaries that have a care plan. So what this means for each practice that is enrolled in the PCMH program is that this activity must be met in order to continue to receive practice support. So in the next couple of slides, we're going to go over how to go in to the AHIM portal and complete the attestation and how to select your high priority beneficiaries that have a care plan. So first off, we're going to go over completing the attestation questions in the portal. So you will first log in to your AHIM portal. This will be your home page whenever you bring it up. You will see the space listed as submit 12-month activities, and it has a due date, so you have to complete this by December 31st of 2017. So once you click on the submit the 12-month activities, as you would normally do, you will go in and you will begin answering the questions to each of the activities, each of the attestations. The care plan attestation falls under activity I, so you may either go right to this one, or as you are completing your attestations, just keep answering your questions, clicking on the attest button. But when you come to activity I on the care plan, you want to be sure to answer questions 1 and question 2. Once you have answered those questions, hopefully you will select yes to both. You will then want to select the I attest that the described activity has been completed. Once you have done these steps, as you can see, step 4 will be selecting the save changes. That is, if you want to save the work you have already completed, say you've already completed some of the other activity attestations, but you have not completed all of them. If you click Save Changes, it will save the work you have completed at that point. Once you have completed all attestations, you want to click Submit, and that's whenever you have completed and you are ready to submit all of your answers. So really that portion is very simple, but we just want to remind you to please be sure to go in and complete this attestation as it is part of the activity. Now, we're going to go through selecting high priority beneficiaries that have a care plan. This process may be completed throughout the year. You do not have to do it all at one time. So if you have some, even right now, that you know you already have the one care plan completed, you can go ahead and go into the portal and begin selecting those. So to do so, again, you're on your home page in the portal. You would click on Submit Care Plan Attestation. Now, I know this slide looks very busy. However, if you just go step by step, it's really quite simple. So whenever you click on Submit Care Plan Metrics, you will be brought up, your page will bring up a list of all of your beneficiaries that you have selected as high priority. As you can see, in this example, you want to click on the box under Select First Care Plan Update for that respective beneficiary who you know has a care plan. So you will click that box. If you know that that beneficiary has an update to the care plan, you can then go in and select Second Care Plan Update. Once you have gone through and you have made all of your selections, you will want to click on the I attest box and also click on Save List. But I want to point out, as throughout the year, as you are selecting your care plans, up in the right-hand corner, there's a little box on this slide. But as you are selecting your care plans, the system will calculate these for you. So that way you can keep up with your percentage of care plans that you have attested to. And again, I want to point out that the percentage of attested care plans should be at least 80% of your high priority beneficiaries. So a few tips on care plans and what you may need to know. CPC Plus practices are also required to complete care plans. In the previous performance years, if a practice was enrolled in the PCMH program as a CPC practice, they were not required to complete any of the PCMH activities. In 2017, that has changed. Any practice that is enrolled in the PCMH program, regardless of enrollment in the CPC Plus program, will be required to complete care plans as well as the other PCMH program activities. Next, we've had several questions about who can initiate a care plan and who and how a care plan can be updated. So a care plan may be initiated by an APN or an RN, meaning they may gather the information on the patient. For example, compiling the problem list, documenting blood pressure, A1C, etc. But any decisions about the patient's plan of care should be made by the physician. Also, the physician needs to go in and review and sign off on the care plan. For established high priority beneficiaries, there should be at least 2 updates within a 12-month period. So a new care plan does not need to be created at the beginning of each performance year for your established high priority beneficiaries. For those established beneficiaries, again, there should be at least 2 updates to the care plan within that 12-month period. For any new high priority bennies, there should be an initial care plan and an update within a 12-month period. More tips. So updates to the care plan may be completed by an office visit or over the phone. So just like the initial care plan, the update may be initiated by an APN or an RN, but the physician is responsible for reviewing the care plan and signing off on it. Templates. We've also received many questions about using templates. Yes, a template may be used to complete care plan. Just be sure that you address all of the required elements on that template. If your template does not include all elements, you may also submit any supporting documentation to help with our review. An office visit note, progress note, as well as a good SOAP note that includes all of the required elements may be used as care plan documentation for this activity. These notes are not part of the requirement for the activity, but are alternative options. Remember, if a problem is listed on the care plan or a note, it must be addressed. Deadline to attest and select your high priority beneficiaries with a care plan, again, is December 31st, 2017. This is a very important date to remember. This is the deadline to attest to having care plans and the deadline to select any of your high priority beneficiaries that have a care plan and an update in the medical record. So let's go back to the topic of templates just for a moment. I want to show you in the next few slides, we have some examples of good use of templates and not so good use of templates. So in this example, this one is a very good example of use of a template. As you can see, it lists the patient's problems, the instructions for follow-up. It has a good assessment of each problem, and they have included the update. You can see the initial, or the first one was done on 6/15, and the update on 10/16. Here's another use of a good template. This is much like the previous one. You can see, lists the patient's problems, there is a good assessment, there is instruction for follow-up. And then there is also the update. Here's another template, just in a different format. Again, it's still a good use. It has good assessment and status of the problems listed. And as you can see, there is also the follow-up. So you can use different types of formats, just as long as you get all of the required elements on your template. Another one, much like the previous one. And here's a good narrative note. Each problem that is listed on this note has an assessment, and this gives us a good picture of overall how the patient is doing. And this is the update to the care plan that we just had on the previous slide. Again, very good use of a narrative note. So here is another template. This one, not so good. As you can see, the assessment, the problem and status, it does not really provide us enough information. To be acceptable, we would suggest that if you're going to submit this type of template with just these, the status such as new, unchanged, deteriorated, we would like to have either a progress note or some type of note that gives us just a little bit more information on how the patient is doing. So if you submitted this to us and then along with a note, that would be great. But this alone would not pass. Another example at the same thing. Again, excuse me, if we had some type of documentation or a progress note, then we would be able to get the whole picture of the patient. This is another one we received. I believe this is a screenshot. Again, there's no assessment of the problems. So this alone would not suffice. And one more. So again, to be acceptable, additional documentation, for example, an office note or a good SOAP note should be included if you are going to submit something simple like this. Okay, one other thing we want to talk about, addendum to care plans. So adding an addendum is acceptable as long as it is timely. Addendums really should not be created no later than 2 weeks after the visit. After 2 weeks, you kind of lose the purpose of the addendum. An example of an acceptable addendum would be if an office visit is conducted on December 8th and the care plan note did not address any follow-up. Addendum, if the addendum was created then on the 15th that the patient is return to the office in 3 weeks, that would be acceptable because that is within a 2-week period. And I've provided you with an example of an unacceptable addendum. In this example, the care plan was completed, or the patient was in for a visit on July 22nd. I guess the clinic noticed that they had not included any follow-up. So on December 15th, they went in and they did the addendum, which we give them a good, I guess a plus for good effort there. They realized what they had missed. However, that is quite a few months in between, so we would not accept that. And that is all that I have on care plans.
Thank you. And I will say that, and maybe later on, when Alicia Berkmeyer from Blue Cross comes on board, they're looking at care plans as well. They're sort of finding similar kinds of issues. Mm-hmm. So this is, this has been a real work in progress. I know many clinics have said to us that, yeah, this has been a lot of work to change what we do, but many are saying, it really has improved how we deliver care. So we thank you for the efforts so far. And, again, I think as Shelley said, sometimes an annotated problem list may not stand on its own, but paired with the progress note might be just fine. So make sure you send along the documentation you need. We have a couple questions.
Yep, we have some questions for you. Please keep them coming in the chat box. We see some people have raised their hand, but we would prefer if you would type in your question in the chat box and we'll answer them live. Shelley, this one's for you. Can you tell us some common failures that you see on care plans? What are some of the biggest mistakes or the most common mistakes that you see?
What we are seeing the most right now is not enough information on the assessments. We will have something that simply says uncontrolled. Well, we need, such as for hypertension, uncontrolled. We need a little bit more information on how have you determined that that is uncontrolled. Again, if there was just a little blurb, something, I don't.
And I think we also talked about the follow-up, a specific date or a time frame for a follow-up rather than as needed. Or
that is correct, which fortunately we have not seen as many as in previous years, but we have ran across a few where the follow-up is PRN, return to the office if not better, things like that. We do need something a little more specific.
One or two of the examples said uncontrolled, and besides no assessment, there was no plan for the uncontrolled too.
Correct. That is correct. So that has been our biggest thing that we have noticed. So.
Question regarding speech therapy, occupational therapy, and physical therapy. Do they need to be included in the care plan and the update?
Well, I would say if there is a problem that is,
I think that if you identify a problem getting that therapy, I think stating that the patient is receiving that therapy might be adequate.
Agreed.
Yeah.
Agreed. But as far as like physical therapy, speech, and occupational therapy notes, I don't think we need anything of that nature.
What about can LPNs or other, who else in the staff can complete care plans?
So that would be your nursing staff, your APN, your RN. An LPN could gather the information, but they do not need to be responsible for making any decisions.
And this is where we look for maybe a physician sign off, right?
Correct.
We can have a LPN put it together and we can have the physician review it.
Absolutely.
Keep in mind these are your high priority beneficiaries, so they are your riskiest patients. We definitely want the PCP to put their eyes on that care plan at least once a year just to see where their most needy patients are and how they're doing. So there's nowhere on the manual that requires you to do that, but we think it's a best practice for the physician to be aware of what is going on with their high-risk, high-priority beneficiaries. Any other questions in the chat box?
We can circle back to at the end if we have time. Why don't we move on to the MMIS update? So we'll give you the floor and give us the good stuff.
All right, very good. Hello, my name is Stephen Tongi. I am the PCMH Program Manager for DXC Technology, formerly Hewlett-Packard Enterprise. I'd like to spend a few minutes with you updating you on the new MMIS claim platform implementation and how it affects PCMH quarterly deliverables. Just quickly, on April 1st, 2017, Hewlett-Packard Enterprise Services merged with Computer Science Corporation to form DXC Technology. You may see some new logos soon and our name on correspondence. Emails will have a dxc.com ending to it. Also, you'll see some new emails and that name when you call the call center. So just kind of want to give you a heads up on that. But now the new MMIS implementation is scheduled for mid-2017. So in the middle of this year, the enhancement brings cutting-edge claims processing technology, a new online provider portal, and the last implementation of this complexity was over 35 years ago. So about the time that the Rubik's Cube kind of came out, and the original Home Alone movie. So it's been quite a while. So
35 years since that.
It is 35, actually 37. So some of the features of the new system will be a new online provider enrollment application. You'll be able to submit claims and view status online, adjust and void claims. There's a new electronic prior authorization functionality, electronic uploads for attachments to claims and PAs, view and print remittance advices, beneficiary eligibility verification, real-time claims processing. So all really good stuff. I'm not here today to train you on the system, but I would think that your best place as a resource is on the graphic on the page, and which is the frontline link. Should be something that you utilize. It's for updates, training, operational readiness questions. So look for the frontline link on the Arkansas website page, and also your AFMC outreach specialist can also assist with any questions you may have. Okay, so let's kind of get to the rollout schedule and how it affects everyone that's participating in PCMH. Basically, the new MMIS does not affect provider participation in the Medicaid PCMH program, but it may affect the timing of Q3 and Q4 deliverables. Otherwise, the change to the new system should be seamless to the provider community. The graphic above, or the graphic shows how the implementation rollout occurs in phases. So there's the current environment, which is what we're in right now, the implementation, which is anticipated for mid-2017. After that, there's about a 4 to 6 month stabilization period. And that's just time that folks are working behind the scenes to make sure everything is working just the way it should.
When you say PCMH deliverables, you're talking about report cards?
We're talking about reports, PBPM care coordination payments. So those things that the PCMHs, the provider community, gets in support of the program.
So there might be some speed bumps in the usual rollouts of materials.
Yeah. So, and we're gonna get to some of those speed bump descriptions. Obviously, it's very important to us. DMS has made it quite clear that it's very important that we don't disrupt the program. DXC is working very closely with DMS in order to make sure that those things happen in a timely fashion and as normal as possible. So the takeaways here to these different phases is that replacing MMIS is a fairly complicated undertaking. It's been 32 years, as I mentioned, since a system like this has been last upgraded. The new claims processing capabilities, so you'll have new claims processing capabilities, but the same PCMH program. Rollout of the new MMIS may affect the timing of some PCMH deliverables, particularly in third and fourth quarter. And you can expect some changes to the addendum, for example. Okay, just kind of wrapping up here. So illustrated are PCMH deliverable timeframes for 2017. What you have shown there is for first quarter and second quarter. You have the PBPM care coordination payments, the PCMH reports, 2015 shared savings, the final payout for it, and there's clear dates that have been established for each of those. The PBPM payments are complete. The PCMH reports, for first quarter, you should expect next week, and shared savings is right around the corner. In fact, letters for shared savings are going out today. Because of the anticipated implementation of the new system in mid-2017, Q3 and Q4 dates have not been determined. Every effort is being made to provide Q3 and Q4 deliverables in a normal time period. We'll know more as we'll get closer to the release date. DXC is working, as I mentioned, with DMS to identify exactly when these deliverables will occur. Note that the timing and delivery of PBPM care coordination payments and shared savings payments are DMS's highest priority to each of you. So, and that's just wrapping up things here. So really, this concludes my presentation of the MMIS update. If there's any questions, please.
We will have time at the end to go over that as well.
We certainly will.
And again, we are hoping at Medicaid that the enhanced capabilities of a new system, once this gets stabilized, we hope to change our reimbursements for co-location of behavioral health and primary care settings, and a variety of other potentially enhanced ways of delivering information to your practices. So we're looking forward to it, and we hope Stephen and his team and the folks that he works with will have a smooth sailing ahead. So we're all looking forward to it. Oh, yes, you want this. All right. Now the important stuff.
Hi, I'm Ann Santifer, and I'll be talking a little bit about shared savings today. You may have noticed on Steve's slide that we did not mention Q3 and Q4, and that's because things are still uncertain at this time, but we'll try to definitely make sure payments for sure are going out very closely to the same time frame that they went out in previous years. That is definitely one of our biggest priorities, payments and reports. So we'll try our best within the new system to make sure those happen around the same time that you guys are used to seeing those. So shared savings, the good stuff. Like Stephen said, we have shared savings letters going out today. So we have 22 practices. They're eligible to receive and share in the savings. We'll be paying roughly close to $5 million, I believe, for 2015. Shared savings has always been one of the biggest incentives for our program. It's something we do very well and something that it's a very exciting time for us. So how do you qualify for shared savings? Well, first thing you have to do is you have to be enrolled for the entire performance year. For 14 and 15, we had practice, well, now even today, we have practice support activities and metrics. So you had to meet your practice support activities and metrics in order to be eligible for shared savings. For quality metrics, you had to meet at least 2/3 or 67% of the quality metrics in which you're being measured on. So we only measure you on a quality metric if you have at least 25 beneficiaries in that category. So for example, on your 3 to 6 wellness visit, if you have less than 25 beneficiaries that fall within that age range, we will not count that as a metric for your practice. Pediatric practices tend to have the kids, and then the adult practices are not held accountable for kids and vice versa. So you also have to have at least 5,000 attributed beneficiaries to be eligible for shared savings. And you can do that in 3 different ways. You can either do it individually if you're a large practice, a standalone, or you can pool either with your friends, or you can pool by participating in our default pool. And what was really exciting for 2015 is we had 67,000 beneficiaries in our default pool, and together that default pool was able to produce savings of at least 2%, which is the last requirement in order to meet shared savings. So great job, default pool, and everyone who was able to reduce the cost. So we have 2 different ways to determine shared savings. We have what we call the absolute method, and we have the performance improvement method. We'll always pay you whichever method yields the highest shared savings or the highest payment. For absolute performance, and you can find all this information on your quarterly report. So I will reference the wording that's currently displayed on your quarterly report so you can refer to it and kind of estimate how you can get shared savings. So under absolute performance, your average total cost of care per beneficiary is below the median threshold. So you have a little bar graph on your report. As long as your average total cost of care is less than that median threshold, you can be eligible for 50% of the savings. The other method is the performance improvement method. So on that one, we look at your previous year's performance and your current year performance. You can get anywhere between 10% to 50% of shared savings. That will be determined upon where your benchmark falls. So when you look at that little bar graph, there's there's a gray triangle in the 2015 report. That's your benchmark cost. If your benchmark cost is in the area that's considered the high threshold, you'll be eligible for 10% of the savings. If your gray triangle is in the green area, I believe it's called the medium threshold, you'll be eligible for 30%. And if you fall below the medium threshold, you'll be eligible for 50% of your savings. Basically, the difference between your current average total cost of care and your last year's performance. So how do you calculate your shared savings? Well, you get your report out. The first thing you want to do is look at your average total cost of care. Under absolute performance, it's pretty easy. You take the medium threshold, you subtract your average total cost of care per beneficiary, then you multiply by 50%. For performance improvement, you take your benchmark cost, subtract your average cost per Benny, then you multiply either by 10, 30, or 50, depending on where your gray triangle is on that bar graph. After you calculate that, we will risk and time adjust your shared savings payment. So risk is your risk score. So how risky are your patients? You can find that on the bottom of your report. The risk score on the report is displayed and truncated at 3 decimal points, but that real number is something like 16 or 19 decimal points. You can get pretty close with 3 though. Keep in mind, you do have to save at least 2% in order to be eligible for shared savings. We're required to have a shared savings cap, and the current cap is 10% of your benchmark. So your shared savings cannot be more than 10% of your benchmark. For pooled practices, we're going to look at your total cost of care and your benchmark at the pool level. Okay. And then when we talk about risk and time adjustment, we do that at the clinic or at the PCMH level. Those clinics that are in our default pool, your cost is measured at the default pool, but your quality metrics is measured individually at your practice level. Oh, I went by quick. So like I said, we have 22 practices. They're receiving shared savings for 2015. Letters are going out today, so your letter will either say, yes, you qualify for shared savings, or it'll say, no, I'm sorry, you do not meet the requirements to qualify for shared savings. We also have a handful of practices that have requested reconsiderations of their metrics. Those practices are going to receive a special letter that says, no, you don't qualify, but your results are under reconsideration. There will be information on those letters on how to request a reconsideration for shared savings.
We also have a runoff period, right? So is there a period of time?
Nope. As far as paying shared savings?
Yes.
The first payment is going to go out on April 28th. Looking at Stephen over there, he's shaking his head. And we'll do an additional payment later on after we review all the reconsiderations. We want to, after you receive your letter, you basically have 30 days to file an appeal or reconsideration. So we'll wait until after that time. We'll review everything that we have received, and then we'll make a secondary payment either later in the month of May or maybe sometime this summer. It'll just depend upon how many reconsiderations we have and how much work it's going to take to review all that documentation. We have been receiving boxes upon boxes of chart notes and records, so it's quite a bit of work to go through everything, but we have a good process in place. We definitely want to give you guys credit if you have seen a patient and the service was billed to another provider, or maybe like in the breast cancer metric, we see it a lot that practices have gone over the beneficiary has gone over their benefit limit. If you've done the service, we definitely want to give you credit for that. So reach out to PCMH@afmc.org, and they can give you some pointers on what we're looking for as far as reconsiderations. I think this is also a good time to talk about caseload cleanup. So this is something that practices never really thought about in the past. But for our patient-centered medical home program, you receive a financial incentive in the form of the per member per month for each beneficiary that you have on your panel. As long as you're receiving a financial incentive for that beneficiary, then you're held accountable to provide care to that person. It's probably a good idea to go through your panel at least once a year, I would say, and just see if you have patients that you haven't been able to reach for years, or you know they're just not coming in, they're non-compliant.
You're 35 and you're a pediatrician.
Yeah, they're 35 and you're a pediatrician. You should definitely remove those beneficiaries from your panel. Otherwise, it could negatively affect your metrics because you're not going to be able to do a wellness visit on someone that now lives in Louisiana or Arizona or wherever.
Bentonville versus
Or
Lakeville.
Bentonville versus Little Rock, right. So just if you have any questions at all on how to clean up your caseload, please reach out to our reps at AFMC. There's a pretty good little process on how to remove them from your panel. That will stop any financial incentives you receive. But as long as you're receiving those PBPMs, you're going to be required to provide care to them.
And conversely, some practices have said, what happened to Mrs. Jones? I see her almost every month, and she's not on my panel, and surprise, she's on somebody else's panel.
Yep, people switch off, so they can switch off primary care physicians as many times as they want, I believe.
Well, the patient may not know they're not on your panel.
Yep, or they may not know. So it's just a good practice to at least once a year go through your panel, see who all's on there, remove anybody. And that way you also making room for other patients who could come in who are interested in participating and following all the requirements of our program. Do we have any hot questions in the hot box? The chat box.
What percentage of total PCMH practices are gain sharing?
Are receiving share savings?
Yeah.
22 out of 135?
About 15, 20%. Yeah, and again, this year we recouped 100% of the PMPMs before shared savings.
Yep, that's right.
Last year it was only 50%. We did that as sort of a introductory special. Medicare, the CPC Classic, always recouped all the PMPMs before shared savings. So.
That's right. So we paid out almost $15 million in per member per month payments in 2015, and practices had those per member per month payments added on to their total cost of care. Last year we only did 50%, like Dr. Golden said. So it made a difference on some practices. We actually saw the majority of them were able to reduce the cost by at least 2%. So that was a positive cost avoidance for Medicaid in general. So thank you for the great job y'all did.
But in terms of total shared savings distributed, some about 80% of what happened last year, close to it?
Yeah, pretty close. Yeah, shared savings. I think after we finish reconsiderations, we're going to be very close to the same amount we paid last year.
Mm-hmm.
Any other questions?
We'll let you think them out here. I'll make a couple comments about PCMH while the questions start coming together.
Yeah.
And I don't have a lot to say, but I will say that we issued our first medical neighborhood report. It's on the web. You can look at transparently how the ERs in the state prescribed antibiotics for the common cold. You might find this interesting. This is our first effort in, if you will, transparent reporting of performance. We are planning additional types of reports like this for PCMHs to look at, to maybe discuss with their colleagues outside of their practice walls, or perhaps guide referrals. So we think the first medical neighborhood report went very well. We may do something with the other payers as well on something like hysterectomy performance, that kind of activity. So, and again, as we move to the MMIS, we may actually get to be more nuanced in that regard. We are meeting regularly. The payers are meeting regularly in the state. I'm going to turn that over to Alicia from Blue Cross very quickly, very soon. We're meeting weekly about PCMH, QHPs, CPC Plus. We are all working together with the health department to make a better health information exchange. In particular, we are in active discussions with Michigan that has something called MyHIN that can help extract data. We believe the payers want to take the burden of the data extraction from electronic medical records off of the providers if we can, reduce the financial hits that you get, and improve our registries so you can get more real-time data on your performance, and also help the health department with things such as immunization registries and other kinds of reporting. So we're very excited about this, and this is a high priority item for the next year, year and a half. We are working closely with ONC in Washington and others to make this a reality. So we're cautiously optimistic about good stuff coming. We also have in beta testing a spreadsheet for each PCMH on their use of prescribing opioids and benzodiazepines and sleeping pills for their patients. So you can see how you do compared to other PCMHs. It will be blinded. You'll get your own data. But we thought, given this day and age, you might find that to be of interest. And we may be sharing that with the payers, the other payers as well. On the CPC Plus side, we have been looking at the benchmark data. The benchmarking data for quality and how you get paid your bonuses. I would suggest you all look at that carefully. It is based on PQRS data submission. The payers in Arkansas, and we're discussing that with the other states, have concerns about the validity of that data. We have already had an active discussion with CMS, and we'll be sending forward to them some alternative suggestions. But I would strongly urge CPC Plus practices to go through that and look at the benchmark data document and what that means to your practice. Let me stop for a second and turn it over to Alicia Birkmeyer, Blue Cross. She can give an update about their PCMH program and the CPC Plus activities. Hopefully, Alicia's on the phone. And
I think so. Alicia, you are unmuted, so you should be able to speak up.
Excellent. Good afternoon. Can you hear me?
Yep.
Perfect. Just a couple updates on CPC Plus this afternoon. One of the things, probably the most important highlight, is that if you don't already, please mark your calendars for May the 26th. We will have our first in-person learning event at the Benton Center. We really apologize that it is the Friday before Memorial Day. Due to the size, we were limited on locations. We hope we can get attendance, and we will do better in the fall session. In the fall, we are hoping that maybe we are working with, as you are aware, TMF is their regional learning for Arkansas. Rachel Wallace, many of you that have worked in the past, will continue to be the lead. She has hired one resource and is in the process of looking for another staff member to support the 182 practices. We're also coordinating with Rachel on development of a learning and diffusion, kind of a regional field team, trying to make sure that we can access and offer resources to all of the practices that are need the different levels of support. One of the things that we're trying to address, and if practices have any suggestions, we're very open to them. But now that we have the 182 practices, we've got some practices that have been doing this work for 4 and 5 years, while other practices are new. So we would like to see if there's an opportunity to maybe also get some of the more experienced practices involved. So if you have an interest, we would love to hear from you how you can help us train and educate some of the newer practices into the PCMH and CPC Plus. Another thing we're doing is trying to kind of look at practices based on their self-report and identifying how the insight visits and also the phone check-ins will go on that. Communication, making sure everyone is connected with CPC Connect. I think we as payers would like to hear from you all. How is the communication going? We as payers have sent the message to CMS that sometimes we're overwhelmed with the communication and the delivery method. Hopefully you guys aren't being as overwhelmed as we are in some ways. But if you are, we'd like to hear, and anything we can do to help, we would sure like to do so. In addition to working in Arkansas this year, CMS has asked us to kind of enter some of the new markets. So Kansas City is one that, Kansas City, Oklahoma, and Arkansas, We've just had this week our third multi-state meeting. We've hosted the first two here in Arkansas, and we traveled to Tulsa this last time. What we're trying to do is, as several regions can come together, can we coordinate and support programs in reporting and auditing? Where are ways we can learn from one another and build upon what we've learned? Let's see. I think those are the highlights that I had, and happy to answer any questions.
You want to make any comments also about care plans and Blue Cross? I know we had a discussion with Shelley, and anything you want to add to that, or just kind of?
Absolutely. In our PCMH program, the practices that were not in CPC Classic, we also did a care plan audit, just wrapping that up. A little over 4,000 care plans were reviewed. Many of them looked very good. There was about a good percent that didn't pass, was what she referred to earlier, is just you have to attest to it. So we really are working, hopefully that is a learning tool and we can work together, but some very good ones we've seen and some that we need a little bit of work on. We are working very closely with Medicaid team to kind of try to be consistent and work through that process and simplify it as much as possible.
Super. Great. Do we have questions floating through the system here? Or?
There was a question regarding where do I find the CPC Plus benchmark? And I know you guys are, if it's anything like what we're experiencing, you're getting quite a bit of communication from CPC Plus. So I know it came through one of those emails.
It was on a Friday afternoon email, and you know what we might do? It's a single PDF. Why don't we figure out how we can get it distributed?
Yeah, or we'll post it right underneath the webinar on our website. We can definitely do that. Rachel at TMF is our contact, and we'll also maybe put out where can you guys reach out to for questions regarding CPC Plus. We'll do that. We have some questions coming in the chat box, so we'll go through those right now, so please keep them coming. I did want to mention that our legislative session ended last week, I think or maybe 2 weeks ago, but there were a few acts in there that may impact PCMH, so we are looking into that. I know the chiropractor bill will definitely require us to make some changes on how we look at PCMH, right? Because if the primary care physician no longer has to give a referral for a chiropractor, we definitely don't want to hold you guys accountable for that. So we will be making changes to accommodate that. And like Dr. Golden mentioned earlier, behavioral health, the way we look at behavioral health is going to change dramatically in Arkansas. So we are closely monitoring that, and we'll be making changes on how we look at the total cost of care as far as behavioral health, chiropractors, or any other bills that got signed during this session.
Probably the next webinar we'll go into that.
Yeah, that'll be a good topic for next webinar. And we probably want to go ahead and plan on having that sometime in July so we can do it, get you guys some CME hours if we can get it scheduled way ahead. So one question was, where do we find the medical neighborhood reports? So you can go on the AHIN portal, and there's a button on there. And once you click on it, you'll see, right now there's only one medical neighborhood report, but as we add new ones, they will all be placed under that same link. There's a question about the CPC Plus conference. They said there's 2 conferences scheduled that day. I believe there was an original invite for one at the Embassy Suites, and then it got switched over to the Benton Convention Center. So it's still happening the same day. There's only one, but it is at the Benton Event Center.
Better parking and other things.
Yep. Okay, care plans. I think somebody asked to clarify who can initiate the care plan, Shelley, and how does that all work?
Okay, those that can initiate a care plan would be an APN or an RN. Now, or the, of course, the physician, the PCP. As far as the follow-up goes, those may also initiate the follow-up visit. They may conduct either in the office or over the phone. So,
all right.
A question came in regarding CPC Plus metrics versus Medicaid metrics. So there's been a lot of confusion out there about this. So for your Medicaid population, we are following the current PCMH program. We're not going to hold you accountable or any CPC Plus metrics or practice transformations. What we did is we talked to CMS and we aligned our program as closely as we could to CPC Plus. But for your Medicaid population, we're going to follow PCMH program rules and requirements. For your Medicare population, you will follow the CPC Plus rules and requirements.
Yeah, some of the PCMH metrics are pediatric oriented, which they don't have in Medicare. Plus, we are going to have for information the ECQMs, but most of the Medicaid PCMH metrics are claims derivative, so you don't have to do that within your office. Although we will try to do the ECQMs for blood pressure and hypertension control, but that's also part of CPC Plus.
And I know there's been a lot of questions regarding this topic, and the reason we decided to go this way is for two reasons. One, by the time CPC rules came out, it was too late for us to change our program. Also, 90% of all our beneficiaries in PCMH are kids, so we kind of have to account for those kids in the program.
And the benchmark targets that we're going after are the historic average performance of a PCMH practice from 2 years ago. So these benchmarks are based on community performance, i.e. you, from 2 years ago. So they are basically a community-driven benchmark.
And if you are a previous CPC practice and now you're in CPC Plus and things have changed for you, I strongly encourage you to sign up for our practice transformation service. It's free to you for the first 24 months. Medicaid will cover that. And the practice transformation coach can help you transition to a patient-centered medical home, and they can help you navigate the different requirements of both programs. So if you have not taken advantage of practice transformation, please contact our vendors over at AFMC, and they can set you up with some practice transformation to one-on-one coaching to help you navigate all these rules and requirements.
Is Alicia still unmuted? Okay. Alicia, you want to talk about some of the outreach and webinars or education you're doing for the Blue Cross participants? Maybe she's gone.
So it is.
Okay.
I mean,
We can't hear you, Alicia, if you're talking.
How about now?
Okay, now you're there.
Okay, excellent. We do have an Arkansas Blue Cross and Blue Shield CPC meeting webinar on the 26th and 27th of April. That will be some payer specific related to our incentive program. And so most of the communication we really try to do around CPC is coordinated and communicated together as multi-payer, but as you can understand, when it gets into the financials, that is something, and that's what will be covered on April 26th and 27th. And if you don't already have an invite, you please let us know, but you should have an invitation that do the webinars.
Okay. And as we're going through and assembling more questions and comments, we really do rely on comments and feedback from you about planning these webinars and planning our outreach. We do want to hear from you about issues you have with CPC Plus. We've already gotten some feedback from some of the AFMC staff about the specifications for, say, the Pap smear metric. So again, if you identify problems or issues that you're having in meeting program requirements or participation, please let us know. We besides trying to solve your problem locally, if there's something happening that in your practice that we can help solve, we can also potentially visit with either our own staffs or the CMS staffs about global issues regarding CPC Plus that may be easier for us to do than a single practice sending an email. But and if you do have some communication with CMS and resolutions, let us know, because others may benefit from that interaction. So,
a lot of questions still coming in about care plans and that. So a few months ago, it's been a while, I can't remember now, we did a webinar specific to care plan, and we do have that posted on our website. Would be good for, if you still have questions on care plans and how that's done, to look over that webinar. And definitely, if you have specific questions, please reach out to PCMH@afmc.org, and we can get you those specific questions answered.
and the material on the web are the slides and the audio?
Yep, it's a YouTube video with the audio and the slides and the questions and everything. So, but if that webinar still is not answering your questions, we can definitely address them individually, whatever specific questions you may have. See if we have any other questions coming in. We will wait a few more minutes, give you some time to type them in. Oh, can we go back to the single health literacy question? Someone asked to look at that slide. And we will be posting the slides on our payment improvement website under webinars.
I hope nobody has a seizure disorder. That's it.
Is everything okay? Okay. All right. No new questions coming in, so we'll wait. It's 1:12 right now. We'll wait maybe a couple more minutes, or maybe until 1:15, and see what all comes in. If not, we'll close the webinar for today.
If people on the call also have suggestions for future webinars, let us know.
Yep. Just email AFMC and they will let us know. They're our main point of contact. So any questions you may have, just send it over to them.
The good news is that the Arkansas PCMH program and efforts is still considered quite a national model.
Mm-hmm.
So everybody here, everybody involved has really been setting an example for others in other states. So you should feel very good about being part of a new movement and a proof of concept.
That's right. We actually had some folks come visit us from Washington last week to find out what we were doing. How are we doing everything we're doing? So it's really happy, positive news for us. We definitely have one of the leading models in the country, and people are knocking on our door to find out how we're doing. I want to let y'all know we had over 325 people dial into the webinar today. So great job. We thank you for participating. All right. I think that's it for all the questions. We will close the webinar. We'll meet again sometime in July. We'll try to get a date set up a little ahead of time this time to get you guys some CME hours. Yep. And any questions that did not get answered, there's lots of specific questions regarding care plans are coming in. There's two people over here just actively typing away, answering all these questions.
And maybe we can post some of those answers on the web as well, right?
Yep, we can do an FAQ on the webinar.
Yep.
All right.
Have a good weekend, everybody, and thank you for dialing in.
Happy Easter.